Hello and welcome to this module where we will be discussing clinical sciences in respiratory medicine. By the end of this module, you should be able to explain the basics of lung development, understand the relevant clinical anatomy of the lungs, describe basic lung physiology which includes control of respiration, the oxygen dissociation curve, and pulmonary function tests. Let's get started. There are 5 stages to lung development. It begins with embryonic stage, which occurs from week 4 to 8. Lung buds originate as an outgrowth from the ventral wall of the foregut where the lobar divisions occur. Then it enters the pseudoglandular stage, which is from week 5 to week 17. So what happens here is extensive airway branching and the conducting epithelial tubes are surrounded by thick mesenchyme. Next is the canalicular stage, which takes place from week 16 to week 25. Here, bronchioles are produced with increasing number of capillaries in close contact with cuboidal epithelium and the marks of the beginning of alveolar epithelium development. The lamellar bodies in type 2 pneumocytes that produce surfactant are seen by week 22 of gestation. These contain 80% of phosphatidylcholine. Week 24 marks the beginning of the saccular stage where alveolar ducts and air sacs are developed. This stage can last up to 36 weeks. The last stage is the alveolar stage, which begins at week 36 to 37 and it continues until 7 to 8 years of age. Secondary septation occurs with increasing number and size of capillaries and alveoli. An interesting mnemonic that can be used to remember the stages of development of lung is every pulmonologist can save alveoli. E, which stands for embryonic, P for pseudoglandular, C for canalicular, S for saccular, and A that stands for alveolar. The importance of understanding the physiology of lung development is in the absence of liquor, which is produced by fetal kidneys during fetal development. It leads to poor lung growth and a low phospholipid content. Renal agenesis is therefore a cause of hypoplastic lungs. Now, let's look at the anatomy of the lungs. This is the lungs. The right is divided into 3 lobes: superior, middle, and inferior lobe. These are further divided into bronchopulmonary segments as follows. Superior lobe into 3 segments which are apical, anterior, and posterior. Middle lobe into 2 segments which are lateral and medial, and inferior lobe into 5 segments which are apical, anterior basal, posterior basal, medial basal, and lateral basal. The left lung has 2 lobes which are superior and inferior lobe. The left lung is divided into 9 segments, 4 segments which are apico-posterior, anterior, superior lingular and inferior lingular, and for the inferior lobe is divided into 5 segments which are superior, medial basal, anterior basal, lateral basal, and posterior basal. On the right side, the horizontal fissure separates the superior lobe from the middle lobe. The horizontal fissure runs from the hilum anteriorly to anterior chest wall on the right side. The oblique fissure runs posteriorly to anteriorly. As a result, the superior lobe is represented anteriorly and the lower lobe is mainly posteriorly. The oblique fissure runs obliquely at 45 degrees from T4 to T5 to the anterior costophrenic angle, but is only seen on the lateral chest radiograph. The area above the horizontal fissure is the superior lobe. Below the horizontal lobe fissure is the middle lobe, and below the oblique fissure is the inferior lobe. The epithelium of respiratory tract. The epithelium that lines the majority of the conducting portion of the respiratory tract is pseudostratified columnar epithelium with cilia and goblet cells. For trachea to primary bronchus to secondary bronchus, the epithelium in all regions is pseudostratified. For secondary bronchus to large bronchiole, the epithelium changes from pseudostratified to simple columnar. For large bronchiole to small bronchiole, the epithelium changes from simple columnar to simple cuboidal. And for small bronchiole to terminal bronchiole, the epithelium in both these regions is simple cuboidal. Let's talk about the control of respiration or ventilatory control. This refers to the generation and regulation of rhythmic breathing by the respiratory center in the brainstem, and its modification by the input of information from higher brain centers and systemic receptors. The ventilatory control system consists of three basic elements: the sensors, which are peripheral and central chemoreceptors and pulmonary mechanoreceptors; the central controller, which is the respiratory control center located in the brain that integrates and coordinates the information and sends signals to the effectors; the medulla amnestic center located at the lower pons and pneumotaxic center located at the upper pons; and lastly, the effectors themselves, which are the respiratory muscles including the diaphragm that produce changes in the ventilatory pattern. The sensors consist of peripheral chemoreceptors, central chemoreceptors, and pulmonary mechanoreceptors. Chemoreceptors detect the levels of carbon dioxide in the blood by monitoring the concentrations of hydrogen ions in the blood. They work by sensing the pH of their environment through the concentration of hydrogen ions. Peripheral chemoreceptors include the aortic body and carotid body. They do not desensitize and have less of an impact on the respiratory rate compared to the central chemoreceptors. The central chemoreceptors are located on the ventrolateral surface of medulla oblongata and detect changes in the pH of spinal fluid. Pulmonary mechanoreceptors detect mechanical pressure, distortion, and stretch, and are found in many parts of the human body, especially the lungs, stomach, and skin. When the lungs are inflated to their maximum volume during inspiration, the pulmonary stretch receptors send an action potential signal to the medulla and pons in the brain through the vagus nerve. The Herring-Brewer reflex is triggered to prevent overinflation of the lungs. The medulla oblongata is the primary receptor control center. Its main function is to send signals to the muscles that control respiration to cause breathing to occur. There are two regions in the medulla that control respiration. The ventral respiratory group stimulates expiratory movements, and the dorsal respiratory group, which stimulates inspiratory movements. The pons is the other respiratory center. Its main function is to control the rate or speed of involuntary respiration, and it has two centers called the apneustic center, which sends signals for inspiration for long and deep breaths. It increases tidal volume, and the pneumotaxic center, which sends signals to inhibit inspiration that allows it to finely control the respiratory rate. Its signals limit the activity of the phrenic nerve and inhibits the signals of the apneustic center. It decreases tidal volume. The apneustic and pneumotaxic centers work against each other, and together they control the respiratory rate. The chemoreceptors are the sensors for blood pH. The medulla and pons form the integrating center, and the respiratory muscles are the effector. This is the oxyhemoglobin dissociation curve. This curve is an important tool for understanding how our blood carries and releases oxygen. The curve shifts to the left when there is lower oxygen delivery, lower acidity, lower temperature, lower 2,3 dpg, and also presence of fetal hemoglobin, carboxy or methemoglobin. The curve shifts to the right if there's raised oxygen delivery, raised acidity, raised temperature, and raised 2,3 dpg. The oxygen dissociation curve describes the relationship between the percentage of saturated hemoglobin and partial pressure of oxygen in the blood. It is not affected by hemoglobin concentration. On the same note of oxygen dissociation, there are two concepts to be understood, which are the Haldane effect and the Bohr effect. The Haldane effect describes the phenomenon by which binding of oxygen to hemoglobin promotes the release of carbon dioxide. The decrease in oxygen affinity of hemoglobin when the blood pH falls is called the Bohr effect, and is related to the fact that deoxygenated hemoglobin binds hydrogen more actively than oxyhemoglobin. The Bohr effect takes place in tissues that are metabolically active. This is a diagram that demonstrates the lung volumes which are measured by a spirometry or pulmonary function test. Tidal volume is the volume that enters and leaves with each breath, from a normal quiet inspiration to a normal quiet expiration. Normal values are 500 mL in males and 350 mL in females. Inspiratory reserve volume, or IRV, is about 2 to 3 liters. This is the extra volume that can be inspired above the tidal volume from normal quiet inspiration to maximum inspiration. Expiratory reserve volume, or ERV, is about 1.5 liter. This is the extra volume that can be expired below tidal volume from normal quiet expiration to maximum expiration. Now let's look at capacities. Capacities are composites of two or more lung volumes. They are fixed and they do not change with the pattern of breathing. Vital capacity, or VC, is about 4.5 liters. It is the volume that can be exhaled after maximum inspiration to maximum expiration. Total lung capacity, or TLC, is about 6 liters. It is the volume of air in lungs after maximum inspiration. Let's now look at the examples and the characteristics of obstructive and restrictive lung diseases. Obstructive lung diseases is marked by significantly reduced FEV1 with reduced or normal FVC. So in total, you'd expect a ratio of FEV1 over FVC to be reduced. Examples of conditions are asthma, chronic obstructive pulmonary disease, bronchiectasis, and bronchiolitis obliterans. Restrictive disease, on the other hand, has a reduced FEV1 with significantly reduced FVC, and this in turn gives us a normal or increased FEV1 over FVC. Examples of conditions are pulmonary fibrosis, asbestosis, sarcoidosis, acute respiratory distress syndrome, infant respiratory distress syndrome, kyphoscoliosis, and neuromuscular disorders. Total gas transfer. A gas transfer test measures how your lungs take up oxygen from the air you breathe. The result of the test is called the transfer factor, or sometimes the diffusing capacity. TLCO refers to the transfer capacity of the lung for the uptake of carbon monoxide. This table outlines the causes of raised and reduced TLCO. Causes of raised TLCO are asthma, pulmonary hemorrhage, left to right cardiac shunts, polycythemia, hyperkinetic states, male gender, and exercise. Causes of lower TLCO are pulmonary fibrosis, pneumonia, pulmonary emboli, pulmonary edema, emphysema, anemia, and low cardiac output. Let's summarize. The prenatal development of the lung takes place in 5 stages, which are the embryonic, pseudoglandular, canalicular, saccular, and alveolar stages. Complete alveolization does not occur until 28 weeks of gestation, and the complete development of the alveoli and the pores of corn only occurs around the age of 7. The lungs are divided into lobes by the horizontal and oblique fissures. The lobes are then further divided into segments, right having 10 and left having 9. The epithelium of the respiratory tract transforms from pseudostratified into columnar, then into simple cuboidal epithelium as it reaches the terminal bronchioles. The ventilatory control system consists of three components, which are the sensors, respiratory control centers, and effectors. Pulmonary function test is done to differentiate obstructive from restrictive lung diseases. We have come to the end of this module. Thank you.